In Chapter 17, we will be covering the thigh, hip, groin, and pelvis. Starting off with anatomy, we're going to cover bones and ligaments. For the hip and pelvis, we have three bones that are considered a part of the pelvis. The ilium, which is this big elephant ear looking bone right there, that's the ilium. Then we also, as part of that, we have our iliac crest. So if you were to put your hands on top of your hips, basically, and push down, you would be putting your hands on this iliac crest right here. Next, we have the ischium. So the ischium is down here. The ischium is our sit bone. That's those are the bones we sit on, our ischiums or ischia. Next, we have our pubic bone. So that's the bone that comes across the front in our pubic region, and it helps to protect a lot of our important organs there in the front. So we have one of each of these bones on either side, and as a group, they all come together to form the acetabulum, or the joint socket that the head of the femur goes into. So this goes into that when it's inside of our body. Okay, let me get this all erased. Next, we'll talk about the femur. So the femur has a head right here. That's the head of the femur. And then the long part is the shaft. So this is all the shaft of the femur. Then we also have the medial and lateral condyles, or with the epicondyles attached. So the medial condyle of the epicondyle is right down here, and there's our lateral condyle with the epicondyle on it. The epicondyle is the little ridgy part that sticks out from the condyle, but those are places for muscle attachment. As far as ligaments for the hip, there are specific ligaments in the hip. They're not major stabilizers. The muscles are actually bigger stabilizers. The joint capsule is a pretty big stabilizer for the hip. And then we also have the iliofemoral ligament that's going to be really deep inside of the joint there. So you're not able to see it in this picture. But that might help with, say, for instance, rotation of the hip, or to stop against rotation. Next, as far as anatomy of the hip, we have our muscles and tendons. So we have our quadriceps of the thigh that are there in the front of the thigh. And one of our quadriceps, the rectus femoris, actually does cross over and attaches to the pelvis at the AIIS, kind of right in there. That one rectus femoris does extend the knee and flex the hip. The rest of the quadriceps do not affect the hip, but they do extend the knee. Our hamstrings are again on the back of the thigh here. There are 3 letters in ham, and we have 3 hamstrings. We have our semi-twins, or semitendinosus and semimembranosus, there on the medial side, and then we have our bicep femoris on the lateral side. Those all flex the knee and extend the hip. Next, we have our gluteals. So our gluteal muscles are here attached to the backside of the ilium. So we have 3 gluteal muscles. We have our gluteus minimus that we're not going to talk about a lot. We have our gluteus medius and our gluteus maximus. So our gluteus maximus is here. That mostly extends the hip and abducts the leg a bit. And then our gluteus medius is kind of in this region, and it helps to abduct the hip primarily. Our piriformis is deep to that gluteus maximus. So if you want to find your piriformis, if you look pretty much right in the middle of your butt cheek, you can find your piriformis. So let's see, that's not the exact right position. So the piriformis is a ropey-like muscle that runs across basically the middle of your butt cheek horizontally. And it helps to rotate the hip. It's also a muscle that when it is tight tends to cause a lot of discomfort both in the hip, knee, and lower back. We also have our hip flexors. So the hip flexors are going to be on the front of the hip. We have our tensor fascia latae. I also call it the coffee muscle, but usually we call it the TFL. We have our psoas here that attaches from our spine down to the femur, and we have our iliacus that attaches from the front side of the ilium and then goes down to the femur. So those are our main hip flexors there. And our adductors, or our groin muscles, are going to be on the medial side of the thigh. So we have a nice big group of adductors here on the medial side of the thigh, and they help to adduct the hip. As far as hip injury prevention, the hip itself is somewhat vulnerable to injury because of powerful contractions of the surrounding muscles. Most often, if somebody is having hip issues, we spend a lot of time doing appropriate strengthening, and also appropriate stretching. So lots of stretching for the hip to try to prevent hip and thigh injuries. We can use a foam roller. So say for instance in this picture with the blue foam roller, this girl is actually foam rolling her piriformis to try to help loosen that up. And then we can also do stretching after we do the foam rolling. Then this would be a piriformis stretch that we could do here after we've foam rolled. That's a really good static stretch there, so that's preferentially done independent of doing activity or playing sports. So that would be for after a practice or after a workout, or just independently while you're at home watching TV or hanging out or whatever. For stretching, we're going to try to stretch the quads, hip flexor, piriformis, and hamstrings, and groin muscles as needed. We're going to want to strengthen our muscles as well, especially quads, hams, and glutes, and make sure that the person has good mechanics. So if somebody has poor foot or leg mechanics, it could be affecting their hip. I have a patient who comes in to the spine clinic who has a lot of lateral hip pain. She's got a really big Q angle, so a lot of very wide hips in relationship to the position of her knees. And she comes in all the time with flip-flops on, and it drives me nuts because they're just not nearly supportive enough to support her feet while she's trying to get her hip to feel better. So we do a lot of foam rolling, stretching, and then also trying to get her to wear her better shoes that are more supportive. Next in our assessment, we'll do history and observation, so our beginning of our hops. Remembering that the information provided here is for informational purposes only. So for history, what's the onset? Was it sudden or slow? Did they decelerate quickly and then all of a sudden feel a pop in their hamstring? That would be a sudden injury. Was it slow over time? So my hip I just noticed one day that my hip was starting to hurt and I'm not really sure what happened. Do they have a previous history of hip, back, or knee pain? What was their mechanism of injury? Their pain description, so sharp, including intensity. So on a scale of 1 to 10, how bad is it? Quality, is it sharp, stabbing, dull, throbbing? Duration, how long does it last? Is it just during activity or is it all the time? And where is it? Observation, we're going to look for postural symmetry. So sometimes people can have a leg length discrepancy, or one of their ilia can be rotated forward and the other one is not. So that would cause some possible pain on one of the hips or legs. If we're going to check the hip for size, deformity, swelling, and discoloration. This can be a challenge if we're actually talking about the hip joint itself, because sometimes a lot of times it's covered by clothing, and we want to be very careful about how much we expose that skin if we're working in more of a fitness setting or an athletic training setting. So we have to be a little bit cognizant of that as well. But definitely if we're looking at the thighs, that's usually a little bit less awkward. Looking for skin color and texture. Is the athlete in obvious pain? Are they able to walk, or are they limping a lot? And are they willing to move their leg in a normal fashion? As far as palpation, we're going to want to palpate the soft tissue of the thigh and hip. So starting anteriorly, then posteriorly, then medially and laterally. Again, being cognizant of where we're touching the person, making sure we're not in any red zones or in any private areas with our hands. And we want to palpate for pain and tenderness. If somebody does have a groin or hip flexor injury, we want to tell them where we're putting our hands before we put our hands there and make sure they're okay with that. And we should also try to palpate over clothing. So if somebody, anywhere that a bathing suit would be covering, we want to ask for permission before we touch them there. Bony palpation should be performed as well to locate any areas of pain or discomfort. And we want to use palpation also to assess body symmetry. So I'm going to use my hands to try to palpate and see if their ilia are similar positions, basically. And also same thing with the greater trochanters of their femurs and things like that. A couple of special tests we have are the Thomas test for hip flexor tightness. So basically, if we have the person either laying on the table with their legs straight, or sometimes we'll actually have them on the edge of the table with their leg hanging off the table, because that's a slightly better test. If we draw their opposite knee up into their chest like this, and that leg lifts up off the table, or if their leg that's off the table already down at the bottom comes up really high, we would consider that a positive Thomas test for hip flexor tightness. And that would be helpful information for us because it's basically showing us that that's affecting their movement of their pelvis. Another somewhat helpful test would be a straight leg raise test. So in this position, we're going to bring them up as high as we can. So it's basically like a hamstring stretch. And we're looking for hamstring tightness there. Sometimes a straight leg raise test can also tell us that a person is having low back pain or SI joint dysfunction, because as we raise their leg up, they're going to complain of back pain. But generally speaking, as far as the thigh is concerned, we're looking for them to tell us when they're feeling a big stretch in their hamstring or any pain. And we want to try to stop if they feel any pain. We're not going to push them past pain in that position. Moving on to injuries of the hip, thigh, groin, and pelvis. Our first is a quad contusion. So we've talked about this for a second as far as the myositis ossificans already. But basically what happens with the quad contusion is that an individual will be struck in the front of the thigh somehow. I got mine by getting hit with a baseball. It was no fun. But somebody could be kneed in the thigh playing basketball or get hit with a helmet, possibly if they're not wearing appropriate padding. And that causes some pretty bad bruising. That can cause pain, a temporary loss of function, and immediate bruising. Sometimes these won't actually come up as a visible bruise. The person will just have a lot of pain and dysfunction. For whatever reason, the first couple of days of tackling with rugby, I just see a ton of these. But basically, the person gets hit in the thigh, and then all of a sudden they're having a really hard time running and bending their leg. And it's really painful. So the first thing I have them do is bend their leg. And they look at me like I'm crazy, and then I ice them in a bent knee position, and then they feel better. So we're going to want to do price. So as far as price here, it's mostly padding, ice, compression, elevation as needed, depending on how swollen they get. And it says for pain relief and swelling. And we want to make sure we're icing in this bent knee position for a couple of reasons. One is that these do tend to really spasm down a lot. So if we ice in that bent knee position, a lot of times we're going to actually get them more range of motion while they're icing, because it will feel better. It won't hurt as much to bend it while they're icing because it's numb. And on top of that, if we ice them in a straight leg position, we would go to try to bend their leg, and they may have lost some range of motion if we ice them in a bent leg position, or in a straight leg position, excuse me. We're going to do some rehab, so strengthening is appropriate, probably starting off with isometrics and building our way up. We do want to work to prevent the myositis ossificans. So again, the myo is muscle, itis, inflammation, ossify, creating bone growth. So we want to try to avoid the calcium deposits that can happen from bad bruising. And again, if we think somebody has that, those calcium deposits would show up at least 2 to 6 weeks after injury, so not right away. And if this does happen, if we don't protect them enough from this, then they might have to have surgery to remove those calcium deposits. So we really want to work hard to make sure that bruise is covered appropriately. I oftentimes, especially with lacrosse players, men's lacrosse players are the worst for this, because they're so used to getting hit with their hard lacrosse balls, and they don't want to put a pad on something that's been bruised. But it's important to try to prevent that myositis. So I usually will just tell them, just put a pad on it, make me feel better. I won't be as concerned about you developing this bad condition where you have to have surgery. So we're going to want to pad them for return to play. As far as strains to the quads, adductors, and hamstrings, our mechanism here is going to be a sudden stretch or a sudden contraction. This is more likely to happen when the person's fatigued, so possibly towards the end of a game. If they have postural issues, if they have a leg length discrepancy, or again, one leg appears to be longer than the other, if they have a lack of flexibility and or have strength imbalances. Signs of a strain would be pain, point tenderness. So if somebody has a strain, they can usually put their finger on the spot directly that hurts, or they can draw a line with their finger. It's not going to be the whole muscle hurts. That's different. That's usually delayed onset muscle soreness or a muscle spasm. They could have some muscle spasm as well with a strain, so their muscle could feel tight or hypertonic. They could have a loss of function, so they may not be able to walk or run normally, and they may have some bruising. As far as a complete tear, they'll have some disability, discomfort, and deformity. So on this slide, this is right here, that's a picture of a rectus femoris tear. So that person has completely torn the rectus femoris. It looks pretty bad, but actually, after the initial inflammation has gone down, the person can function totally normally. They have 3 other quads that do the same thing, so it's really not that big of a deal, and some other hip flexors that do the same thing. So tearing your rectus femoris is actually not a huge deal. It just looks funny. Our treatment for strains would be price. As far as protection, usually the person doesn't need crutches, but I've had a couple people go on crutches for a bad hamstring strain. Neoprene sleeve or just a thigh sleeve will support when they start going back to return to play, or sometimes we'll use a large A-strap. As far as return to play, a grade 1 strain, the person's going to be able to return pretty soon, usually within 1 to 2 weeks. A grade 2 will take at least 2 weeks to feel better, often closer to 4 to 6, and a grade 3 can take months to improve. These strains are likely to reoccur because of scar tissue buildup, especially if they're not properly stretching and strengthening after the injury. Another injury that can happen with the thigh would be a femur fracture. Femur fractures are rare in sports outside of something like BMX or other high velocity sports like ski jumping. Usually this is more common with a car accident or in a high velocity trauma. Usually femur fractures involve the shaft of the bone, so somewhere kind of in the middle of the bone. And again, these require a great deal of force. So these are going to be more likely to happen in the case of a car accident, say for instance, than playing football. It's not impossible that it could happen playing football, but it's very unlikely. Usually these occur in the middle 1/3 of the shaft of the femur. Our signs here, the person could easily go into shock. There's a lot of blood vessels that run, major blood vessels that run up and down the femur. Also the femur in and of itself makes red blood cells in the bone marrow, and so there could be a lot of bleeding when it comes to a femur fracture, so the person could easily go into shock. The person's going to have pain, swelling of their thigh, and a deformity, so it will look like that whole leg is shorter than the other one. You can see here in this picture that the bones have actually been pulled past each other a few inches because of the forceful spasm of the muscles surrounding the bone. The person's going to have a severe loss of function. They probably won't be able to move their leg at all. Our treatment for this would be call EMS. We're going to treat for shock, check nerve and blood supply. So we'll try to check the dorsal pedal pulse in the foot if we know how. We'll also check them for sensation and the ability to move their foot. EMTs will splint the person before moving in a traction splint, which will hopefully pull the pieces of bone into a straighter line, but oftentimes there's so much spasm it doesn't work necessarily as well as it could. So on this x-ray, the person actually is still in their traction splint from when they were put on the ambulance. It just wasn't very effective at pulling them into a straighter position. And a physician will reduce that femur following an x-ray, and it does require emergency surgery. So I believe that they, generally speaking, will put a rod down the femur, and I'm not sure if it's also commonplace to probably use plates or screws or something like that as well. That's going to be a fairly long recovery from that surgery probably. Femoral stress fractures are not quite as bad, at least, as regular femoral fracture. Our femoral stress fractures here are generally from overuse, so quote-unquote overuse, where the person has been training and doing something that they're just not strong enough to do, so too much force is being transferred to the bone. This is an uncommon injury, and it tends to occur in endurance athletes, so usually marathoners, triathloners, things like that. It's also more common in women than men. Most stress fractures are more common in women than men for a lot of different reasons. Signs of an injury would be that the pain is going to occur weeks after increasing workout intensity. They're going to have persistent pain in their thigh and groin. So when somebody has pain to the hip joint, usually they also have pain into the groin, and this is kind of near the joint there. The person's going to have pain in the thigh and groin, especially after activity. They could get pain referred as far down as the knee. They're going to need an x-ray or bone scan to reveal the fracture. And these are commonly seen in the femoral neck. So this is the femoral neck through here. And these are rarely seen in the shaft of the bone, although it is possible. When we're looking at these x-rays, we have 3 different x-rays here, or diagrams or pictures. This would be a compression stress fracture. This would be a tension stress fracture. And this would be a displaced stress fracture. So with the compression stress fracture, that person might be okay with maybe just being on crutches. With the tension stress fracture, they may be more likely to, and also with the displaced fracture there, they're going to be more likely to need to be non-weight bearing because the leg weighs a lot. So if they have that tension stress fracture, even if they're on crutches and not bearing weight, that leg is going to be pulling on that stress fracture. So they may end up actually having to possibly go in a wheelchair to get some of the pressure off of that kind of stress fracture. One of the more interesting things about this particular injury is I actually did have a student one semester who had this injury, and it was from lifting, which is very unusual, and he was working out other than that as well, but he really noticed it a lot with lifting. And he was a 20-ish-year-old guy who was not an endurance athlete, who actually was on the bigger side, but not overweight. So that he wasn't like what we would think of as the common person to have one of these stress fractures. So we don't want to get stuck in thinking this could only happen with women that are endurance athletes. Our treatment would be, our initial treatment would be rest, then strengthening. So rest is relative, so either on crutches or possibly non-weight bearing completely in a wheelchair. Most people with femoral stress fractures will heal with conservative management. If not, they might need surgical repair, probably pins of some sort, kind of going through that region. Next, we're going to talk about hip dislocations. Again, this is another injury that does not happen very often in sports. It may happen in football or rugby when somebody big is landing on top of another big person, possibly, but these require a lot of force to happen at the distal end of the femur, so at the knee, basically. So an example of this would be the knees hitting the dashboard in a car accident, and the knee needs to be in a bent position for this to really happen. The knee needs to be driven backwards into the hip joint. Our signs would be basically the person is stuck in this leg position. So the knee is flexed, adducted, so coming across the body, and internally rotated, so the hip is kind of coming this way. And they're not able to move out of that position because the head of the femur is stuck out of joint, basically. It's stuck, usually the femoral head is going to go posterior, so back towards the buttocks. This is considered a very serious injury. There's a lot of soft tissue and nerve damage possible, and often the person can have a fracture from this as well because it takes so much force to knock that very strong hip joint out of place. This might be more common in people who have shallow hip sockets. Some people are just born that way. That's a possibility as well, and in that case, they're less likely to cause serious damage like fracture. Either way, our treatment here is to call EMS, so call 911 if that's our emergency number, primarily because the blood and nerve supply may be damaged, so we really want to make sure that the person is not going to lose their leg from this dislocation. Reduction of hip injuries is difficult, so even if somebody is a chronic hip dislocator, the person's still going to need EMS to come out and get them so they can go to the hospital and have their hip reduced. Most likely, or they are not going to be able to do it themselves, and it might be hard for somebody else to even do it themselves, even if they knew how. After a hip dislocation, they're going to be immobilized in some kind of a splint for 2 weeks, and they're going to be on crutches for at least 1 month. Hip and pelvis fractures are also uncommon in sports. The hip and pelvis are very strong bones. They don't commonly fracture. Most commonly, we have hip and pelvis fractures as a result of a direct blow or a blunt trauma. So we're more likely to see this in a car accident, or somebody is struck by a car while walking, say for instance, or on a bike, or a motorcycle accident. These are common. The only time, I can only think of one time off the top of my head that I was actually concerned about somebody having a pelvis fracture, and he was a basketball player who went to go dunk on the basketball hoop, and so both his feet were up in the air. He went to go drop back down, and another player was running towards him and basically undercut him and took out his legs, and he fell directly on his pelvis, on his back. So I did end up having to call 911 for him because he was in so much pain. He was from the other team, so I don't know how it ended up turning out, but he was the only person I've ever been actually really concerned about possibly having a pelvis fracture, just because he fell from about 4 to 5 feet in the air directly onto a hard surface on his pelvis. These people are usually in severe pain. They have a severe loss of function. They're not going to want to move their legs at all if they can help it. They could go into shock, possibly. So our care here would be to immediately treat for shock, call EMS, so call 911 if that's our emergency number. And basically, the seriousness of the injury will be dependent on the extent of shock and the possibility of internal injury. Our pelvis protects a lot of very important organs, so if we fracture the pelvis, sometimes there's also serious internal injuries as well. So on this slide, we actually have 2 hip joint type injuries. So we have hip sprains and hip labral tears, and it can be a little bit interesting to try to tell the difference between these two if we're not cognizant of taking a good history, because they both cause pain in the hip joint area. So a hip sprain happens when we have a violent twist due to forceful contact. So this could happen if somebody's foot is planted on the ground and then they're tackled and forced into a backwards rotational movement, possibly. Or it could be from a cut and a plant and twist, possibly if they did it hard enough. Our signs here would be signs of acute injury, so they won't want to move their leg, they're going to be having a lot of pain. A big thing for the hip sprains is that they're not going to want to rotate their hip or circumduct their hip. So they're not going to be able to do that. It's going to hurt too bad. That's one of our telltale signs for a hip sprain. The person's going to have pain in the hip region, so probably more laterally versus medially. And hip rotation is going to increase their pain. For a labral tear, our mechanism is usually more repetitive overuse. So it's not a violent twist, it's from overuse usually. We can get a labral tear along with the hip dislocation, because the head of the femur kind of knocks off a piece of the cartilage on its way out of the joint. So that's also a possibility. Oftentimes, hip labral tears actually don't hurt or cause any discomfort. So just because somebody has a hip labral tear doesn't mean it's a huge, huge issue, because sometimes they don't even hurt at all. Oftentimes with this, our signs would be clicking, locking, or catching. A labral tear they'll have pain more in the groin, so more into the medial side of the hip joint versus the lateral side of the hip joint, like you might have for a hip sprain. For labral tear, they'll also complain of stiffness, and their motion will be limited versus the other side. Our treatment for hip sprain is going to be price and NSAIDs, possibly put the person on crutches, and then we're going to delay their rehab until the hip is pain-free. As far as treatment for a labral tear, we're going to do rehab. We're going to try to increase their pain-free range of motion, increase their strength, and their balance. We'll do price and NSAIDs as needed, so they shouldn't necessarily be on crutches unless they're in a lot of pain. We want to actually try to get them to use the leg more in a safe manner. And the hip labral tear may require surgery if rehab fails. So we may try a few weeks to maybe 6 weeks of rehab, and if they're not improving, then we would make sure that they were seeing a surgeon. But if we think somebody has a labral tear, they should see the doctor sooner rather than later, even if we are doing rehab, and then the doctor can decide from there whether or not they need to see the surgeon. Piriformis syndrome is I would consider it a relatively minor injury, but it can be also very painful. So for some people, it's really problematic. It can cause a lot of problems. Basically, what happens is the piriformis, the muscle in the back of the hip, that little rope-like muscle right here, gets really tight. And the sciatic nerve, or the bundle of nerves that runs through that muscle, gets pinched on by that tight muscle, and it causes nerve pain. Nerve pain sucks. So this can be very painful. Basically, it's usually, again, from a compression of the sciatic nerve due to tightness and or a spasm of the muscle. Sometimes people call this sciatica. Oftentimes people refer to any referred pain down the leg as sciatica, but this is technically what would be defined as sciatica. Signs here would be pain, numbness, and tingling in the butt. Pain can increase with sitting, climbing stairs, walking, and or running. Our treatment here would be stretching and massage. So we don't really want to massage directly over the nerve so much. We really want to hit more out here towards the lateral aspect of the buttock region. So we're not actually causing any further compression of the nerve with our massage. The person's going to do piriformis stretch, like a figure 4 stretch, and sometimes hamstring stretches are helpful as well. Medications, we could take NSAIDs, and sometimes a doctor will do a cortisone injection or corticosteroid injection if the person's not doing well with stretching, massage, icing, things like that. The biggest thing here is we want to avoid aggravating activities to the extent we can. Sometimes the stretching, the piriformis stretching, will actually cause a little bit more increased pain and tingling, but it should resolve afterwards. So if the person is having increased pain and tingling for more than 5 minutes after stretching, then they need to probably modify what they're doing. But it would be fairly normal for them to have some increased discomfort while they're stretching, and then that should fade afterwards, just because you're putting a little bit more compression on the nerve while you're stretching the muscle. Last but certainly not least, for our injuries here in our hip line, groin slides, is an iliac crest contusion, and this is a contusion to the iliac crest and the pelvis. And it also can kind of cause some bruising on the abdominal musculature. Sometimes it's a little higher up in there. These are very painful. These do not feel good. These are results of a direct blow, so some kind of being hit with an object. So common in football, when somebody gets hit with a helmet. In basketball, somebody could get kneed in that area by somebody else. My most recent was a lacrosse player who got hit with a lacrosse stick right in that area. His was not quite so colorful as this gentleman's, but it was very, very painful for him. We also call these a hip pointer. I'd say generally speaking, if an injury has a nickname, it's pretty annoying or pretty irritating. But these are really painful. Anytime you have an injury to the hip musculature or the abdominal musculature, that can be really painful because those muscles stabilize people while they're moving pretty much constantly. Even in sitting, your abdominal muscles are working somewhat. So it's really, these are really important to try to help with pain relief. Sometimes people cannot play with these. I mean, even though it's just a bruise, you know, sometimes people have a lot of pain with these. The lacrosse player I saw, he actually told me he had like 8 or 9 out of 10 pain from this. And it's actually not too surprising. They're very painful. Our signs here would be pain, spasm, and temporary paralysis of the soft tissues. So the muscles just may not work properly, and they're going to be very painful. They could have decreased trunk rotation or thigh or hip flexion due to their increased pain. And they probably will also have some reduced speed if they're expected to be changing direction. Our treatment here would be price and NSAIDs. So we definitely, if somebody's going to try to play with one of these, we need to put a big old pad on there, the biggest pad we have, to try to keep them from getting hit there again. A lot of times I'll also put an ACE wrap over the top of that to try to help support the area. Sometimes I'll even do like a wrap that covers the whole area, including the groin area sometimes. If we think there's a possibility of fracture, we would have them go for an x-ray. Again, these bones are very strong. So I remember the lacrosse player I worked with had it, asked me like, oh, do you think it's fractured? And I said, it's possible, but you get hit with an aluminum stick. It's really, that bone is way stronger than an aluminum stick, so I doubt it. Again, we really want to make sure we're using padding upon return to play to minimize chance of added injury. And also, if they get hit there again, they're just going to be down on the floor. They're not going to be able to keep playing. So I've had people be resistant to putting a pad over it since it's just a bruise, but it is very important to pad that area.